May. Thank you all for being here. This is Primary Care Day.
Every day is Primary Care Day.
And there are some people in the room who like primary care.
Yes.
Helen, would you like to lead them in song?
Hold up the finger on you.
I led them yesterday.
Yes.
How will this
Okay.
affect the patient? Help the patient.
Help the patient.
Help the patient.
How will this save money? No,
No, that's
That's his line.
we all have our.
So we have a list of folks who are going to talk with us today about various aspects of primary care. Before we get to that, I would like to make one announcement, and that is that we released today a decision in the second of our health insurer rate cases. We are new to this business, but we now have a role in the health insurer rate review process, and this particular rate review related to Blue Cross Blue Shield's administrative expense load for the coming quarter. They had requested a increase in their administrative expense factor attached to their rates of 5% originally. For last quarter, the Commissioner of Insurance knocked that down to 2.9%, and they had asked for that to be rolled ahead, the 2.9% increase to the upcoming quarter. We currently are under the constraints of we have to complete these reviews within 10 days of receipt from the Commissioner of a recommendation, and we have only the choice of voting it up or down. We can't modify the Commissioner's recommendation. So the Commissioner recommended that we approve the 2.9% increase. We looked at this as thoroughly as we could within the 10-day time frame. We had some real concerns about the 2.9%, and those are noted in our decision, which is available on our website. We have, however, decided to approve this for the upcoming quarter, but we note a number of our concerns, and I'll just read from our decision one of them that I think is particularly important. We're concerned about the rate of growth in Blue Cross Blue Shield's administrative expenses. Our review shows that the company's 2012 administrative expense budget is more than 9% higher than its actual 2011 administrative expenses. So if you don't look at the 2.9% increase, but you look at what that actually translates into in terms of an increase in their total expenditures for administration, it's a 9% increase. And includes budgeting for employee wage increases and bonuses at a time when most Vermonters are not seeing similar, if any, increases in income. To the contrary, many Vermonters have been tightening their belts, have seen their health insurance premiums increasingly eat into their wages, and have experienced a marked trend toward higher cost sharing. At the same time, healthcare providers are being asked by this board to undertake serious cost cutting and restraint in their revenue growth. So the long and the short of it is we approved this, but we plan to take a much closer look at how these requests are constructed in the future and the implications for overall affordability of healthcare costs in the state. Anybody want to add anything on that?
No.
Okay. All right, our only other task before we get to our agenda is approval of minutes, and we have, I believe, just one here, right?
Move to approve the minutes of Tuesday, May 8th, 2012.
Second.
All in favor?
Aye.
All right, thanks. So I think Dennis is up first. We have on our agenda today Dennis Barton from the Office of Primary Care and the AHEC program. We have Charlie McLean. Do you pronounce it McLean or McLean?
Either way.
How does your mother pronounce it? From the UVM College of Medicine, Steve Trombley and Jill Korinsky from Planned Parenthood of New England, who are going to talk about Planned Parenthood as primary care providers, and Hannah Rabin from Richmond Family Medicine, who just walked in. So Dennis, you can take it away.
And I'm going to ask Charlie to join me up here. I I think the catalyst for this discussion, and by the way, Dennis Barton, I'm Director of the Office of Rural Health, and I'm sorry, that's my old job. I'm Director of the Office of Primary Care and the AHEC program at the University of Vermont College of Medicine. I do have previous experience working in rural health and primary care areas. I think that the original kind of catalyst for this discussion, besides being a fan club for primary care, was the publication of this report, which is really a snapshot of primary care. We do this on an annual basis. We thought it was important that this information get in front of the Green Mountain Care Board. So it's you each have a copy of this, I think, and we have more copies available. And I can highlight that very briefly. That was kind of the original, our original concern. And I think we can highlight some of those issues, but I've also included in there as part of our introduction. We often get the question, what's an AHEC? Area Health Education Center, and what do you do? And so generally our overall mission is really to improve access to primary care in Vermont, improve the quality of care being delivered. But I think one of the best ways to look at it is in terms of this particular graphic and material, which speaks to the pipeline of workforce development that we're engaged with as AHEC programs. We have a central program office and we have 3 regional AHEC centers that are independent but affiliated with the program office. And if you see by looking at that continuum, we start in elementary schools and middle schools, secondary schools, introducing the concepts of healthcare careers in the state of Vermont, introducing them to the potential for that possibility, and then working through this entire process, this entire continuum with various programs, first of all, to enhance choice of healthcare careers, which we all know there's a lot of areas where there could be more Vermonters engaged in healthcare. And then we start to work through with professional students, and we are involved then with programs that enhance their experience, their residencies in primary care, so they get the experience, especially with an emphasis in rural primary care. We've often discovered that if people are involved in residencies and experiences in rural healthcare, they like it. If they try it and they like it. So we're in a lot and very much involved with that. And as you see, as we go down that continuum, we're involved with medical school graduates in terms of having them come back to practice in Vermont, especially if you receive financial assistance, and retaining Vermont practitioners in primary care. So we administer the education loan repayment for the state. We've been doing that for a number of years. And then after they've been here, providing continuing education and other kinds of educational programs. And I think Charlie can talk a little bit about that, because a lot of what we're involved in is in quality improvement in primary care practice settings, and that's universal across the state. But I wanted to provide kind of this highlight in this kind of pipeline that we're involved with, just to give the board here a sense of what we do and how we do it and why we do it. Beyond that, I think I would just introduce Lori Horowitz. And Lori Horowitz is a consultant with us. She's a former staff person with AHEC. And Lori Horowitz is the author of this report. So I've invited her to join us in case there's any questions near the end of our discussions today. I would also, full disclosure, there has been a previous relationship with you and Anya, my understanding is. Yes.
She's a previous
that
staff person of
relationship. We'll go
Probably worked for half the people.
So Anya was PPQHC, and that's where Lori was before she came with us. So it's been great to have Lori. And she does have the experience of having done this report for many, many years and understanding the trends and the concerns and the issues. And I think Charlie can highlight some of the concerns. I would like to believe that our job here today is to really talk about the state of primary care, what we've discovered in terms of our basically analytical work, in terms of the workforce, what we've been able to determine, but also in terms of what our experience has been in terms of dealing with a lot of different types of primary care practices and working with these primary care practices as they've experienced healthcare reform. And I think that's a critical issue, is that if we're talking about primary care as being centric to the system, healthcare system, and patient care being centric to our approach, that we want to make sure that our primary care workforce is engaged in these healthcare reform activities like health information technology, the blueprints, so forth. So we want to actually have strategies, and we hope you'll promote strategies and decisions that will enhance their role, their capacity to work in the state. And I think Charlie will be starting to identify some of the barriers and some of the obstacles and what are some of the measures that could be taken to help improve that situation, really in the long term. That's the way I kind of saw it. Was there anything that we should include in our presentation that would be of concern for the board that we'd want to cover today?
We'll figure it out by the end.
Okay. And I recognize we have other speakers. So what I'd like to do is turn it over to Dr. McLean, and I think he's got some remarks he wants to discuss.
So we were here in November of 2011 presenting to the board, and I'm not sure I have a whole lot new to say, so I'll make my remarks actually fairly brief and then be open for any kind of questions. But when we were here before, we set out to make the case that primary care is foundational to high quality care, and that it's also foundational to transforming the healthcare system because of the relationship between primary care and quality and the sort of centrality of coordinating care appropriately across primary and specialty care. And so there's a whole universe of data around that, studies that I think I gave you some references to before, and I'm happy to answer any questions that relate to that. I think when it comes to where are we in Vermont in terms of our primary care system, there's good news and there's bad news. So I think I could give you the option of which you want to hear first, but I think the good news side of it is that we have a very high quality primary care workforce, number one. Number two, it's a relatively cohesive workforce. People work well together. In the work that we do through UVM and a lot of outreach for educational programming and what I consider things that are central to retention of people in primary care, sending students out and having folks participate as preceptors for our learners. And this applies both to physicians and to nurse practitioners, to a certain extent also for PA students, so the existing PA workforce as well. Those activities all create a really nice climate to practice in Vermont. Relative to other parts of the country, we're fortunate to be not as short of primary care as some other places. And the Commonwealth Foundation or Commonwealth Fund right now has, I think, probably the best up-to-date interactive tools to map out what's the availability of primary care and what's the relative quality of care delivered in different parts of the country. So I use that as my favorite sort of pointer to if you want to look at variation across the country. So I think that's the good news part of it. We have some good programs in place to help promote primary care, including federal programs like the National Health Service Corps that we really try to promote and drive people to the extent that they're appropriate for it. And then we also have an education loan repayment program that is directed at primary care, at nursing, at mental health, at a wider range of fields, but all that are, I think, important to delivery of primary care. And the funding for that is from the legislature. It varies from year to year, and I probably couldn't say enough about the importance of that to the recruitment efforts. That funding is often matched by the employers, so B. Grouse is in the audience, the hospitals that are employing people. I think the folks from Bi-State are here. Those are the kinds of organizations that often match that funding and really make it, increasingly leverageable. So I think that's all great. The things I'm most concerned about are the aging of the current primary care workforce. So Alan presented yesterday at a rural health symposium, and David Reynolds was there. And I did a survey of the audience around the issue we were talking about, which was narcotic diversion and narcotic prescribing and how to do a good job with that. And I did a little survey on the fly while we were doing the presentation, and one of the questions I asked, just for interest, was how many years in practice people had been. So this fairly representative group of the docs in the Northeast Kingdom, the mean years in practice was 15, which was a pretty high number. It's a little scary. So I worry a lot about the aging of the workforce. And we've been through the last 15 or 20 years through a decline in interest. We're hoping that that trend is now reversing. And so in the last couple of years are a little optimistic on that. I'm optimistic about the next few years in that regard because of the growing numbers of medical school graduates and the stable number of residency positions in the country. It's going to really, I think, help fill up some slots that otherwise wouldn't be filled up. I think any efforts that can be made to improve the work conditions of people in primary care would be another huge factor in promoting retention and recruitment. And I think that's obviously very pertinent to the work of the Green Mountain Care Board. So when I spend part of my time, being a flag bearer and a champion of primary care, both at the College of Medicine and the College of Nursing and Health Sciences, and then also around the state. So I do get to get out a fair amount and talk to people in practice. And the things that I hear as the most concerning when it comes to people currently in practice, so this is less about sort of the pipeline of who's choosing these careers, but about who is actually in practice, are things like large administrative burdens of things that don't necessarily improve patient care. So they may be put in place for a variety of reasons to control utilization or to save money or whatever, but prior authorization, varying from insurer to insurer, changing, one of the strategies that I think is very intentional is that prior authorization methods often, or forms and whatnot, change all the time. Every time I prior approve something, it seems they've changed the form, which just makes it, I'm sure it's intentional to drive me crazy, but things like that, I think really get in the way of people enjoying their day, spending time doing the things that they're trained to do, see patients, interact with them and their families, share decision making, coordinating with specialists, communicating well. So I think that's one big issue.
Ironically, we were told by the actuaries in a session we had on benefits that it also doesn't save money.
Right. Well, I would argue with that, and so I'm speaking now not necessarily as a faculty member of the university, but as a private individual. I think that the intent of a lot of this is to just wear people down. So I know people who are friends of mine, I know people who are patients of mine, who just don't bother anymore. It's like, okay, you got to get the prior auth. I'll just go to Walmart and pay cash because it's less hassle than really going through this onerous process. So I think it's actually highly effective, but not because the denial rate is high. I mean, everyone knows that the approval rate of MRI prior auths is very, very high. And I think in general, Vermont primary care providers, and I think this is probably true in my experience of specialty providers too, we have a very conservative healthcare workforce where we are not quick to operate on people or intervene or order a bunch of tests. And anyone who practices up here has a segment of their geriatric patients or people retired who spend part of the year in our southernmost states where the pattern of utilization is exceedingly different and where the threshold for testing is very low. And we all see that every year at this time. I saw somebody this morning who was in Florida, had a little something, MRI of the neck, boom, 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 like tests that probably in Vermont would not happen. And you can argue about what's the appropriate level of utilization. We have a culture here that I'm very proud of in terms of both the primary care side and the specialty care side of it. So I think preserving that is key, and I think the PA process, the administrative stuff, is one that is a real big dissatisfier for most primary care providers. The other thing I wanted to just touch on briefly is the healthcare workforce planning work that we had done last year with some federal funding from HRSA. And there was several recommendations from that report that's been submitted to the legislature and to the feds. And there were 4 recommendations that we made that were in the area of, preserving pipeline development programs and building on those, recruitment and retention programs, improving sort of the systems part of things, the infrastructure, and within that I would include one other potential place for improvement for the daily work of primary care, and that is improving the information systems part of it. I think there's a fair amount of frustration, and we heard this yesterday at this meeting we were at around the sort of Tower of Babel of, EMRs that don't communicate with each other. And I think having information at your fingertips obviously leads to better care, safer care, and it's just a lot less frustrating to try to find stuff. That being said, I'm ecstatic about the progress we've made in the last 2.5 years since we've installed EMR. It was painful. It's painful for everybody. Most of the primary care docs in the state have gone through it or about to, and so I think we're on a great trajectory as far as that goes. If somebody can make them all talk to each other, it'll be a home run. So then the last area that I think that was part of our recommendations from this work last year was the idea of really driving towards a more data-driven way to make decisions, which of course is a high priority for the Green Mountain Care Board. And in the workforce survey work that we do, we go out on the ground and we have, the AHEC is a distributed network across the state. We know who's practicing where, and we survey and keep track of not only who's practicing where, but what's the FTE they're putting in. So we have a pretty detailed sense of who's working where. The other way to try to come at that is really from the actual utilization side. So somebody can tell us, well, yeah, I work 50%, but if we can go to the VCures, for example, and really paint a snapshot of what care is happening where is some of the variation, what are the average panel sizes, is the quality higher in this kind of setting versus that, or is the efficiency better in one system or another? I think that's a way that we can really learn from the data that are available or soon to be available. It was really an impossibility to do before VCures really contained all of the information, and now, from my understanding, we have Medicare on the verge of being in, we have Medicaid in, so I mean, again, there's progress being made, but I think that is a tool that I have confidence will be very useful and interesting. One of the other things that's kind of frustrating for primary care, and others who are testifying today or other people you'll talk to can probably confirm this, we are in receipt of lots of rolled up information from insurers who are trying to, very legitimately manage care and improve it. And if I get a report that's culled from administrative data that is inaccurate or incomplete and only represents 5% of my population or 10 or 30 or whatever, it's really hard to work with data like that. So taking an all-payer claims data set and getting accurate, up-to-date, reliable reports that can be really something I can really work with and change my office processes around, compare myself to my peers who are working in similar settings or different settings, look at best, who's the top performer, and really try to emulate that or learn from it. I think that's an approach that would be welcomed by primary care. I think that most of us are less motivated by the sort of pay for performance financial incentives and more motivated by trying to do a better job. Now, that being said, there are the issues around, payment and reimbursement discrepancies that have evolved over the last 10, 20 years with the RUC that probably need to be addressed as well. And, whether that can happen at the state level or the national level probably remains to be seen. So I think I will probably stop with that and I guess ask if there are any other questions that you have that I can
I
try
have
to
a
answer.
question, and this may be a question for Lori. In terms of benchmarks in this report, where do you derive the benchmarks from?
It's derived from a very old standard. So,
Jesus, Tom.
and it's on.
Director Tom.
It's derived from an old standard, the Graduate Medical Education Board. The how many, as you know from our work at BBQHC, is always a question. So what we've done is been very transparent about our methodology and put the raw numbers in here. So if someone else wants to compare how many to a different standard, the data is available. But we've used this old standard from the 1980s when everyone was concerned that medical schools were putting out too many physicians. At this time, the world has kind of turned around and we're concerned about are there enough. But what we've done is use this across time, and it's a very quick calculation. It's a calculation of how many people, 100,000 people to physicians, and then we say how many should there be from this older standard, but we back it up with 2 other pieces of information that have us feeling that it's pretty solid way of looking at the world. One is that we're finding in family medicine and internal medicine that the number of practices that are closing or limiting their practice to new patients continues to go up. And those are the areas where we're saying there is a shortage. So there's a correlation between the two. The other is, as part of our Freeman Medical Scholars Program at the University of Vermont, we're always looking to identify openings in Vermont for those who have received scholarship and are in residency training all over the United States, but they're College of Medicine graduates and have a commitment to practice here. And we see a similar number of openings in Vermont in family and internal medicine combined as we look at in this report when we say there's a shortfall in those 2 specialties. In the same way, in pediatrics and obstetrics gynecology, in using these older standards, we find there is not a shortfall. We also find that those practices aren't limiting new patients, and we also find that there are very few openings in Vermont. So I'd say it's an old standard, and it's a very broad brush stroke, but it's easily collectible, and it's supported by some additional information that we have.
2 questions about the external forces that may or may not influence primary care in Vermont. One is the recent announcement about enhanced primary care rates from Medicaid, and I'm wondering whether or not that's a big fix, a little fix, a helpful fix. And the second question has to do with interprofessional training that AAMC and ACGME and others are promoting, and how that's playing out here.
So in response to the enhanced payment, I think, is that what you're referring to that will apply to FQHCs or
To all primary care doctors. It was just announced, well, the press release was today, and there's something about it yesterday.
It's part of the Affordable Care Act. There's a bump in Medicaid, primary care, and the feds pay for it.
Right, and certainly that would be welcomed for sure, particularly by providers who have a high proportion of Medicaid in their practices. So any little bit is probably beneficial.
I guess my question was it a little bit, or is it substantial? I couldn't tell
30%
from
it says.
33%, but I don't know if that's.
We'll probably see how it plays out.
Yeah.
In terms of the budget, right?
Yeah.
I would just make one other comment, I think, on that. In terms of primary care, there could be a tendency that everybody that's practicing primary care is a physician. There's a certain kind of perception about primary care. But primary care practitioners are many kinds of health professionals. They're nurse practitioners, they're physician assistants, they're doctors, and they're practicing in a variety of different settings. And they're going to respond differently in terms of the particular setting they're practicing, in terms of various initiatives, like the Medicaid initiative to improve their care. And I think it's always important that we segment the primary care practitioner community by setting and by practice, and be sensitive to how, if we're going to adjust one aspect of the system, how each aspect, how those settings are going to respond. It's much different to practice, and you'll hear from, rural health practice than it is in a large Fletcher Allen high, primary care network. And so I think that's important for this board to be sensitive if they're going to make adjustments in terms of rates or any other stimulus or other ways of trying to change the system, make sure there's enough access to primary care.
So the other question was around interprofessional training and even the creation of new job titles that didn't exist, for which there wasn't training before, like panel managers and other categories.
Right. So I think the interprofessional education is something that I know is a high priority for a variety of organizations, including the AAMC that governs the training of docs. And at UVM, we have some efforts to try to train nurses and docs together to the extent that you can. It's very challenging in the medical school curriculum and in the NP curriculum because they're so rigidly locked into everything that they have to do. So during the sort of classroom kinds of activities, it's difficult. We're doing an increasing amount of simulation in the simulation center, as are most colleges of medicine and nursing, and that's an opportunity to get people together working on teams in a simulation environment. My view of how best to teach interdisciplinarily is in settings that function like that. So if in my practice, for example, I am truly working in a team environment with, good interaction between front desk staff, nursing staff, medical assistant staff, NPs, PAs, and physicians, and that we're all kind of on a team, and we're working appropriately with a community health team and whatever behavioral health providers. That's the way to teach the next generation of how to do it, is to have them truly experience it. So particularly in medical education, I think in the NP curriculum and in the PA curriculum, the bulk of the clinical education is an apprenticeship model. You show up and you learn, in the actual practice setting. So the way to make it work is to practice that way and have the learners tagging along in that environment. So to the extent that we're practicing in an effective way, I think our next generation will be exposed to that.
So do all blueprint practices, or how many blueprint practices, have medical students, interns, residents, nursing students as part of their setting?
There's, I probably don't have an exact number on that, but I could get you an estimate of the proportion of practices in the state that take different kinds of learners. I know we work with a lot of the family practices in the state. Many of the practices along the Connecticut River take Dartmouth medical students as well. PA students, we get requests all the time from PA students from outside the state to say, hey, can you help us find a clinical rotation in some rural spot? And to the extent that it doesn't displace our own students, we try to help with that. It is a challenge for us always, and an ongoing part of the work at the College of Medicine and in the College of Nursing and Health Sciences, to find good preceptors who are willing to do it, because it's a volunteer job. We don't, reimburse them, and it takes time out of their workday. They get home later. I've surveyed them in the last 2.5 years, and time, I can't get home to my family. Those were the two biggest reasons that people felt like they couldn't do more precepting. That being said, most of the people who do it love it, and that's why they keep doing it. So it's actually an activity that might be something that would be worth funding in some way, if it would help promote the educational process, get tighter links between colleges of medicine and the practices around the state. I think that'd be welcomed by both the schools and by the providers.
Yeah, I agree. I've been struck by the unfairness of the whole graduate medical education payment system, where you work in the hospital and the hospital gets paid a tremendous amount for that teaching activity. You go 3 miles down the road where the student may, as Dennis says, is going to get the kind of education that's going to bring them into a community to practice primary care, and they don't get a thing. So there is, you agree, there is that clear discrepancy and fairness between how we fund teaching at both the College of Medicine level and the graduate medical education level.
Yes.
Okay. Now, the second thing is, how closely are scholarships and loan repayment linked to primary care, in your opinion? Now, Laura, you mentioned the Freeman Scholarship Program, and if you look at all the Freeman scholars over the last few years and exactly what specialties they chose, you are not going to see a majority of them in primary care specialties.
So
Okay? And then the second before you get to that is, in the scholarship program, we know that through the FQHC and the National Service Corps, we've got some control over scholarship money being directed to primary care. Where else do you think we can establish some control over scholarship repayment and a closer link to primary care careers?
The National Service Corps is very specific about loan repayment or scholarship programs, very focused on underserved, with a numeric scoring of where you can go, and also on what fields, what specialties are appropriate. So, and the state education loan repayment program closely mirrors that. So it's primary care, it's mental health, social work, nursing. We had a special emphasis, and still do, on nurse faculty, because one of the kind of impediments to getting more nurses out was a lack of nurse faculty, so there's a special designation for that. So those programs are focused on underserved and on primary care and the things that are tightly linked to it. The Freeman program...
Just talk about scholarships in general. Is there any way to link scholarships to primary care in a reasonably effective way? We couldn't do it through Freeman.
No, but I think through NHSC and through the state program, we do. I think they are very tightly linked. If you're a specialist, you are not eligible for NHSC or for state ELR.
But if somebody gives $100 million
Yep.
to the College of Medicine, okay, it says, this is to go, who's that going to be? I don't know. But this is going to go to...
Alan, I refuse to give half my money.
All right, yeah. Al's the business guy here. You ever see a way that that could be, if it was a unrestricted grant, could be directed, knowing the need that we have in this state, and that everybody has to take some responsibility to primary care?
Oh, absolutely. I think that's a policy decision that could be made that would have a lot of face validity to it, and it's, I think, not too difficult to build the business case to say, if primary care is the foundation, what proportion of our healthcare spending goes to it? What proportion maybe should go toward it? So what's the right sort of ratio of primary to specialty care? Then that would be a useful way to frame it, to say, well, if there's $100 million, sure, we need general surgeons in small community hospitals too. There's a bunch of things that we need, and it could be, I could imagine a scenario where there could be a proportional assignment to different things that might change over time. You know, it's like, if you look at the success, if you will, of some of the nurse practitioner training programs, there isn't a huge shortage of nurse practitioners in Vermont today. There are people looking for jobs who can't find jobs. So I think that's been a success story. And maybe we'll get to the day when, you know, there's too many primary care docs, but that'll probably be long after I'm gone.
I could just speak briefly to educate, just for your audit. The state appropriates $870,000 per year, and that appropriation is matched for education loan and payment. $445,000 of those funds are dedicated to primary care. And like Charlie said, a lot of that is really mimics kind of federal standards in terms of health professional shortage areas. We have many more applicants than we have dollars to award. But the success rate is very, very good. Our retention rate for educational loan payment, and they have to sign a commitment that they're going to do it, is in the high 80s. So these folks that do get involved in loan payment, it's a very effective strategy. It's been documented. And if there was going to be more investments, also again in terms of retention and recruitment of primary care educational loan repayment is one place to look.
Any other questions for these guys? All right, thank you very much.
Thank
Thank you very much.
Thank you.
Good to see you.
Good to see
All
you.
right, so Steve and Jill, I think are up next. Anthony, you're going to be raising up.
Are you ready?
Yeah, ready, thanks.
Thank you. Thank you so much for having us here for Primary Care Day. It's very exciting. I'm Jill Krowinski. I'm the Vermont Public Affairs Director for Planned Parenthood of Northern New England, and this is Steve Trombley, our President and CEO. And I think what I'm going to do, since this is our first time in front of you, is just give a brief profile of where we are in the state and who we serve, and then hand it over to Steve to talk about the policy. And we have copies of the PowerPoint presentation if you'd like me to. Great. So who we are. So our mission is to provide, promote, and protect access to reproductive health care and sexuality education so that all people can make voluntary choices about their reproductive and sexual health. Planned Parenthood of Northern New England has 20 health centers across Vermont, New Hampshire, and Maine. And in 2011, we had over 44,000 patients, totaling over 65,000 visits. And we also have over 200 employees across the 3 states. In Vermont, we have 10 health centers where we saw over 17,000 patients and where we had over 25,000 visits. We have health centers all the way up in Newport all the way down to Brattleboro. In Vermont, Burlington is our largest health center where we saw over 5,000 patients last year with over 7,000 visits. We are currently in the process of opening 2 health centers, one in St. Johnsbury and the other in White River Junction. What we do. Providing high quality and affordable health care is incredibly important to Planned Parenthood's mission. In fact, 64% of our patients last year had an income of less than $16,000 per year. We provide abortion services in select sites, annual exam, contraception and emergency contraception, pregnancy testing and counseling, cancer screenings, STI screenings, prenatal referrals, HPV vaccines, cholesterol screening, smoking cessation. STI testing and treatment and contraception services account for a little more than 70% of what we do. Cancer screening and prevention is another large component of the services we provide our patients, And we often partner with other local community groups like the Hicks Foundation and Vermont Department of Health's Ladies First program to provide free cervical cancer screenings across the state. And this weekend, we are actually doing one down in Brattleboro, which will be our 4th for this year. How we save. Publicly funded family planning services and Title X funding for contraceptive services help women avoid unintended and unwanted pregnancies. In the absence of these services and this funding, the number of teen pregnancies would be 61% higher in Vermont. Funding family planning and contraceptive services saves Vermont money. In 2008, the state saved over $6 million in public expenditures, and family planning is a great investment. We know that every dollar invested in family planning saves taxpayers $4. So the Guttmacher Institute has an amazing amount of information about family planning services and Title X funding, which is where all of these numbers came from. And now Steve's going to dive into some of the innovation.
I'd like to just take a minute and share with you some of where, give you a snapshot of where we are in preparation for healthcare reform and the kind of changes that Planned Parenthood has been going through. We've done a lot of planning here in the state of Vermont, and we're right now in the process, first of all, upgrading our physical plant entirely. So we have 10 health centers right now. We're going to be opening 2 to cover St. Johnsbury and White River Junction. But at the same time, we're also actually redoing or relocating all of our health centers. So we've completed 2 of them. We have 2 construction projects right now, and largely this is driven by our need to have better design to increase efficiency for our health centers and to be able to better control our costs and implement electronic health records and other, which is the next one on there, and other systems to, again, lower our cost curve and increase our efficiency. So we've had a fairly antiquated technology infrastructure, which we have been completely overhauling. We will be going live with our EHR across all 3 states on June 1st. So we are smack dab in the middle of that, and looking forward to getting to where you were 2.5 years later onto the other side of that implementation.
So all 3 states go live on the same day?
Yeah, well, we're going to phase them in over a period of weeks, but essentially the whole system is going live, and we're actually going live with the new practice management system at the same time.
What could go wrong?
Well, all of it works only some of the time anyway. So, no, I think we've brought some people in from Massachusetts who've had a lot of EHR implementation experience at Planned Parenthood. So we think the process has been going really smooth. Knock on wood. We also have been having a lot of internal conversations around what our scope of practice is and what our scope of practice needs to be. And we've been in an ongoing dialogue with the folks at the Blueprint about this. Certainly, we've made our own administrative changes in order to position us to be able to do broader primary care services, if that's the direction that ultimately we go. We know certainly that we're committed at this point to moving forward around the preventative health screening and meeting the goals of the Blueprint. So looking at obesity, hypertension, diabetes, depression, and integrating those screenings into our delivery system. And then the question that we're contemplating right now, we haven't finalized the answer to, is at what point do we continue to do chronic care management at all, or do we pass off at that point, and how does that work? And we're really going through a conversation with other providers and with the Blueprint about what we think will work best, but we certainly acknowledge that family planning can't sit there as a goal outside of the broader health goals in the Blueprint, and so we've been engaging in some important conversations around that. We're also looking at other ways to innovate and to drive, to increase efficiency in our health centers. And one of them is actually we've launched and we'll soon be marketing a fairly extensive program to deliver called Blue Mail, to deliver contraceptive supplies by mail. We see thousands of patients, and the number of patient visits that come in for people just to pick up supplies is enormous. And so to the extent to which we can drive that out of the health center, that both makes it more convenient for our patients and actually makes it easier for our staff. So we've been implementing that. It's gone live, and we're implementing a process where when people check in, they can sign up for that automatically. So we hope to move a significant number of our supply visits out of the healthcare setting itself.
Do you do the fulfillment, or do you have a vendor?
We do the fulfillment ourselves, yeah. And actually, we're fulfilling right now in Vermont and in New Hampshire and mailing into Maine. So New Hampshire has its own set of issues related to it on a whole number of things. And then finally, enough said. Yeah, we have been doing a lot of testifying, but to more hostile groups than this. So, and then finally, we really are taking a hard look at telemedicine, and as you know, we've been working on it this year in the legislature. And for us, there's the near-term goal, which we're going to begin working on this summer, which is to make sure that in our smaller communities, we can utilize telemedicine services to increase access and to maintain access. In Newport, for example, there just isn't the justification to keep a full-time provider there 5 or 6 days a week. But a provider could be there 2 days a week, and we could still be open to renew prescriptions 3 days a week through two-way video conferencing between our health centers. So we've integrated this into all of our technology that we've rolled out, and we plan to do our first implementation this summer, sort of Newport, St. Johnsbury when it opens, and Hyde Park. So really they will share providers, and they will be able to communicate through two-way video conference. In the long term, we have much broader goals for this. We really think that our target market is 15 to 30. It's the primary age of people that use our services. And they want to be able to communicate with us in all sorts of ways. And one of them is to be able to communicate with providers through their mobile devices and through two-way video communication. So to the extent in which we could integrate a prescription renewal with that or some other possible services, that is sort of down the road, one of the things that we're exploring, because we hear that feedback from our patients all the time. That 16-year-olds are looking for all sorts of ways to talk to us, and a lot of them don't involve walking into our health center and sitting down across the table with somebody. So I think that'll be important for us. And then lastly, and then we'd love to answer any questions you have, but I just thought it might be important to share with you some policy considerations that we think a lot about, and I'm sure if they're not on your mind already, they should be on your mind. And certainly one of them is that 7 in 10 patients nationwide actually see their reproductive health care provider as their primary care provider. And for young, mostly healthy women in that age group, their reproductive health care provider or their reproductive health care is a big part of the health care that they consume. And so it's natural that they would see us as their provider, as their primary care provider. And the other thing that's important is that we've seen already from states that have expanded family planning access through Medicaid around the country, it's a critical point of entry for the healthcare system for many, many people. And so we see our role not just as providers of care, but as to being an on-ramp and an entry point into the healthcare system itself. And we've had lots of conversations about how we can expand that role across all 3 of the states that we're working in. I think you all should be aware, if you're not already, that Medicaid family planning match is 90-10, and that's, it's included for not just 90-10 for newly enrolled, but for and the newly eligible, but for you continue to get a 90-10 match for those who are enrolled already, which is critical, I think, here in Vermont. So as we think about how the global commitment waiver and how we approach CMS in those conversations, making sure that there's always attention paid to where that 90-10 match is and make sure that it can be maintained. I think it's obviously in everybody's best interest to make sure that these services continue to get funded and that Vermont can maximize sort of federal dollars coming in. And then finally, and this is a conversation we've had in all 3 states as we think about payment reform, we also have to layer that with the fact that Medicaid patients are granted direct access to family planning providers. And, it remains to be seen what happens in November, but this is something that CMS has been incredibly committed to already over the last 12 months. I mean, there's been a number of states that have tried to sort of come in and make an argument around changing that, and they've really stuck to their ground. So assuming we don't have a sea change of an administration change, which would change a lot, we expect this to be sort of consistent moving forward. And so we need to think about that in terms of how that integrates with managed care and how that integrates with the plan that you're developing.
Okay, thank you. So I'll start with a question. When you have folks come to you for, some of the 7 out of 10 who consider you their primary care provider, when they come for something that is not in your bailiwick,
So we have to refer them out. And so we have.
And do you just have sort of a standard set of folks with whom you have relationships and refer to?
Mm-hmm. I mean, we usually try to provide a standard set of options where options are available. So typically for us, what happens, because we're often, for many of our patients, it's the only time they get an exam. So we're constantly detecting and diagnosing everything from cancer to a wide variety of conditions. And so maintain adequate or thorough referral resources from there. I think there is a subset of that we want to start to move to meet those needs ourselves. So if a patient has a cold, that may be something that we're going to be moving into being able to see that, because our patients say to us, we want to come to you for this as well. So, but that line is not clear at this time.
And say a little more about the conversations with the Blueprint and how you might fit in.
Well, I think, so the conversations have been around two things. One is around what's the care coordination around screening. And we first went to them and said, we're going to move into this area because we think this is important for our patients and it's important for the health goals of Vermont. So where the conversation stands right now is really around that question of, do we want to engage in chronic care management and the case management of chronic conditions or not? And so there's been one conversation around that. There's some.
And what would the connection be with the Blueprint if you were doing that? I mean, would you have a relationship where you were performing those services for a Blueprint practice, or you're just carving out that?
Well, we would be mostly that, the former, that we would do this for a Blueprint practice, or that we would have a referral relationship with a Blueprint practice, because again, some of our patients they don't come to us from the Blueprint practice, so they come to us for their need. And so our job is to figure out if something is detected, where do we continue to take care of them, or do we pass them off? So, and I think some of it's community dependent in terms of where how we think that would work best. So, and some of it's dependent on our own sort of where our providers are and the kinds of training that we have to do a significant amount of training already around the screening, because providers aren't typically doing that. So we're also trying to be realistic about the rate at which we can accelerate provider skills in these areas in a meaningful and a productive way. There's also been Blueprint conversations around the whole question of medical home as well. So, interestingly enough, Planned Parenthood, when I first read the NCQA criteria for medical home, it looked a lot like a Planned Parenthood practice because of how we're organized nationally. We have protocol-driven healthcare, we have the quality committees. A lot of what we do and what is prescribed in there, we already do. But family planning providers as a category cannot get the designation. So we meet all the criteria, but you can't get the designation.
Because of NCQA rules?
Because of NCQA rules. So, the way the Blueprint law is written, the assessment's done, as you know, here, and then you mail it all in and NCQA stamps it. Well, we pass everything, we just can't get the stamp. And so there's been some question about is there value in trying to either look at that legislatively? There's been a national effort to have a conversation with NCQA about this, but they just added pediatrics 3 months ago or maybe 6 months ago. So we don't know, it's hard to know where that conversation is with NCQA. So we've been having a conversation with the Blueprint around this.
Other questions for these folks?
Just given the age group 15 to 30, and looking at what you do, how do you think about your relationship with place-based services like school health?
Well, we have some close relationships in the community with school health providers. At the same time, what we often find in our practices is that that young people will come to us for things that they don't necessarily want to go to their school health provider for. The reality is the sensitive nature of dealing with sexual health topics, and combined with our reputation for being that place that you can go that will be kept strictly confidential, means that a lot of people will come to us. They may get other services elsewhere, but when it comes to these issues, they come to us. So it's harder from the patients more than anybody else sort of make that decision in terms of how they sort of vote with their feet, I guess, in terms of where they go for services. So we can have referral relationships and some coordination, but it's in many ways the very fact that we're a confidential place that has its reputation for being where you go, that is what causes people to come to us.
I'm trying to imagine, and fast forward when all of this transitioning is done, from a patient's perspective, how they would either understand or deal with or not the differences between the Blueprint, Planned Parenthood, and a school-based clinic, for example. Is that important to them, or just that they know where to go when they need X, Y, or Z service? How much integration will we try to do where the complexity and the accountability for what % of the dollar is going to go to whom is all behind the scene, and the person just seems to have a choice of where they want to get the service? Can you envision how much or how little we need to do further integration of, let's say, those three, school health, Planned Parenthood, and Blueprint, from the patient's point of view?
Well, I can certainly envision a wide spectrum of where that, I'm not sure that I sort of come here today with a clear sense of where 5 years from now I think we need to be, honestly. I think I sort of feel like the blueprint and the Planned Parenthood and women's healthcare providers, that integration needs to be there without a doubt, because there needs to be care coordination. If we're engaged in screening, then there needs to be some level of integration that's there. How that relates to the school-based universe, I think I don't have as much clarity on, to be honest with you. So, but I do think certainly we need to be thinking about how we integrate with other primary care providers. And I think from the patient's perspective, in our experience, is Planned Parenthood has a very powerful brand. I mean, you know, a lot of people know about Planned Parenthood, for better or worse, right? So we're in the news, certainly a lot this year. And particularly amongst young people, we do a lot of outreach. We're starting a new peer education program in Burlington this summer. There's lots of work that we do with young people, and they know that this is the place that they can go. So I think from the patient's perspective, it's really it's what happens on the ground and the word of mouth between young people, their experiences with us, that is what's going to help them make the decision about where they want to go for this issue. And I don't think they necessarily see the spectrum of whether care integration is happening or not, as much as maybe I might amongst my provider and my specialist.
Yeah, I agree. You have at least among all my patients over the years, a very positive image. And let me just tell you what I was a family doctor for 30 years in Vermont, in Colchester, and that person would get to 18. You know, they're out of Dr. Dinosaur now. They might be leaving home uninsured and need Planned Parenthoods, need birth control services. So they would almost automatically seek out Planned Parenthood. Do you have is it a sliding scale? If that person would come in, would they get a sliding scale for their birth control, whatever they choose, plus their visit, or tell me a little bit more about that.
Yeah, it's a sliding fee scale, and we've also implemented a new program starting on April 1 that was based on the Medicaid expansion eligibility in the ACA, where they can essentially fill out a very short form and be eligible for the equivalent of Medicaid coverage, so it gets fully covered. So that got implemented April 1st, and people are enrolling and moving into that program. Yeah. Prior to that, it was all done on a flat sliding fee scale, which quite honestly had I think a somewhat ominous evaluation process to figure out where they slid on that scale. I mean, part of what we're trying to do is really work to reduce the complexity of our systems and make things simpler for our patients when they come in the door. So.
And now, again, with the Accountable Care Act, it makes me wonder now that that person could slide back into their own family-based health insurance through age 26. Has that had any impact on, because this is part of your branding too, have you noticed any impact of that on your visits, the number of people you see? You know, I'm thinking, would that 18-year-old who could stay on their parents' insurance policy and continue to come to my clinic, still come to my clinic, or would they choose through your branding, through what they know about Planned Parenthood, to seek you out otherwise? That's what I'm trying to think.
Well, I think the jury's out on it fundamentally. Yeah. I can say that with the work that we've done around improving our health centers and around repositioning our branding, we've seen significant increases. So in this first 4 months in Burlington, if you compare the 4 months since we opened the new health center to the 4 months prior, our patient load is up 30%. So we've actually seen a significant increase in patient volume. And now whether or not somebody is staying on their insurance, how much of that, the private insurance sort of reimbursement has impacted that, I don't know off the top of my head. It would be interesting to take a look at.
You see yourself through the blueprint, you don't see any major stumbling blocks in defining yourself as a primary care facility in the blueprint model, as opposed to the phase 2, which is primary specialty care integration, because you do provide specialty services in terms of abortions. That's a specialty service. Do you see any major stumbling blocks as we look at the blueprint as our primary care foundation for being primary care versus specialty care? I
mean, I think that I'm not sure I would say that I see stumbling blocks. I think that there's a lack of clarity, and that's the conversation that we're having right now, is to figure out where the clarity is and to all be on the same page about that. So I feel like we're trying to be as flexible as we need to be in order to make sure that we're integrating in the right way. And I think there's a lot of interest in making sure, given we serve a sizable number of patients in Vermont, and as I said, we're an entry point into the system for a lot of young women and patients. So it's in everybody's best interest that we figure this out. I think that's the spirit of the conversations I've been having. It's just we don't know what the best line is. And we may try. We may go down that road and say we need to take this farther than we're taking it right now. So the first step for us has been, so we have our own unique sort of internal Planned Parenthood challenges. We have protocols. They have to be approved nationally. So we've been developing the protocols and going through the approval processes to be able to position us to have greater flexibility, because that's tied to our medical malpractice liability.
Great, thank you.
Al?
I had a couple of questions. I think that because you're probably used to controversy and questions that are controversial, my questions are more involving words like revenue, inflation, pricing, because I mean, you're part of the healthcare system that we're trying to obviously improve access, but also look at cost. And so what do you see in terms of your sphere of influence of what is your medical inflation? What are you seeing for pricing pressures? How's your business? Do you know what I mean?
Mm-hmm, yeah.
Is that?
That's I mean,
And
how
if
much
you
time
can't-
do we have? No.
90-10.
I told my wife that you were coming today, and based on everything to do with women's health, I'm on a pretty short leash on what questions I can ask. So I'm going to stick to inflation and things like that. So you could just send me I mean, I guess the point would be is, how do you buy prescription drugs? How do you buy, supplies? Are you doing that through different programs that we wouldn't be aware of? I mean,
Yeah, so
enlighten me, I guess.
Right. So I mean, we'll start with prescription drugs, because I think that's probably the biggest area of our cost structure that we've been focusing on. We actually have a national GPO that we
Didn't see that coming. Keep going.
that we've purchased through, and more importantly, we've actually been working. We have a separate Planned Parenthood nationally has set up a separate corporation, and we are actually entering into private label production ourselves. So we are actually having our own product come into the marketplace starting in 2013 for the
Okay.
major contraceptive pills. So when we control a lot of volume nationwide, what's that?
They'll be blue.
They will not be blue. Though we are actually expanding services to men, including starting erectile dysfunction treatment for men. So, but going back to pills, so I mean, it's a huge part of the
Did you
volume
have
that
to
we
go
do.
there, dude? No.
So,
Keep going.
Go back to that short.
There's like 4 guys in the room.
So I think that's an example of one of the areas where we've tried to control costs, is to try to sort of aggregate nationally. And
I didn't expect that answer, so that's awesome.
yeah,
What's your inflation rate on that? Like how?
we actually expect our costs will go down when that rolls out.
So if you take over all drugs,
what's that?
so if you were to take over all drugs,
Yeah. Yeah, I actually served on the board of this company for the first 2 years of startup, and so I know more about those drug approval processes than I ever want to know. So,
yeah.
but then there are other areas too. I mean, I already mentioned one. So in terms of our cost structure, our malpractice liability. So we have a separate corporation under which we do all risk management, property malpractice, and we've actually been lowering our costs that we charge ourselves have been lowering by 10% every year. For medical malpractice, which is fairly unheard of in the marketplace, and largely because we can manage risk really well, and we have this protocol infrastructure, and we're heavily capitalized. So we've been able to lower our cost that way as well. Around electronic health record and technology implementation, we've set up another management services organization. So we're actually developing our panels collectively, and our implementation strategy and training and all of that, as well as online training, is all being developed centrally, and we pay into that. So we pay a fee to that to get those services back, but we think there's real value in terms of lowering our cost of implementation around those things. So
Funny, with all the national debate about Planned Parenthood, I hadn't heard any of this.
well, they haven't asked me about it in New Hampshire, I can tell you that. But there's a lot that we've done, and we're actually looking at trying to leverage our regional structure. So we're even looking across sort of Connecticut, Massachusetts, northern New England. We may be aggregating our server farms. We may be doing a whole bunch of back-end consolidation to, again, lower our costs as well. Well, we have servers, they're on farms, and, you know, they can all go to the same one, and,
Organic.
So you moved to College Street, right?
right.
That's,
St. Paul.
you moved from,
From
Oh,
Mansfield
From
Ave.
Mansfield Avenue,
Okay.
yeah.
and is that a better location? Is that any of the volume increase, or what do you?
I think it's certainly more visible, and I think one of the things that has happened over the years is that in an effort to sort of avoid either controversy or around fears of safety and concern, we've kept a very low profile, which we've really been doing a lot of thinking about that and decided to change that it doesn't make us any safer and our patients can't find us. So, and we're in the phone book for the people who really want to find us, so it doesn't make any sense. So I think it's more visible in that sense. It's a much better physical layout as a healthcare facility. So it allows us to do things, significantly increase capacity. We can run surgical services and contraceptive services simultaneously, and share staff, which we weren't able to do in the other location. There's a number of things that.
Thank you.
Great, thanks a lot.
Great.
Appreciate you guys coming.
Thank you
Thank
very
you.
much.
Take care. All right, and doing cleanup is Hannah Raven. Welcome, Hannah. How are you?
Good, how are you?
I'm good.
For having me. So I do have a PowerPoint and,
Oh, do you want to load it up?
yeah.
Sam, help her. Thank you.
Take a
Take a break.
Yes,
She
you
doesn't
can take a
wanna lose
break. Everybody
control
wants a
of the
bathroom
entire
break, so.
Anya,
Yeah.
did you know that answer?
Which answer?
So, they're like a Fortune 5 company,
No,
the way they
I
do
did
everything?
I want to join them. They seem to have the financial house in order.
I
So
did
your
not see
suggestion
that.
is going to be that you leave your practice and go join them?
Yeah.
You asked for a break. Maybe we should break.
I just wanted to be able to talk without having to
I don't think so, just
Moved to your town, I
recognize them. Is this,
think.
no,
You
when he
know,
came
he's
in?
married to Sean.
No.
Schedule. In the governor's office.
Interesting. Clark Kent?
So it would be the first one.
That was your break. I thought we were
No,
doing a
but I
break.
wanted,
Yeah.
I am breaking.
Oh,
We're
okay.
talking.
Pictures of
I didn't want to
family.
sit here like we were all like, you know, look, everyone's breaking.
Okay, are we done breaking? Yeah.
As soon as she's ready.
Are you ready? Okay.
I think so.
Thank you, Hannah, for being here. So Hannah's going to talk with us about her practice, which is new and somewhat unique, I think, in Richmond. You guys used to practice together, right?
Well, in a way.
In a way. So Alan was my professor starting
Okay.
and attending 15 years ago.
And when Hannah and I were in kindergarten and first grade, she would not shut up about primary care. We were best friends, and we'd sit there in the block corner, and she would just talk about primary care.
Wanted to be a family doctor.
Yeah.
Anya would bring her doll over to the doctor's office, and then we would have a little health policy discussion.
Yes, and here we are, nothing's different, so. thank
Too
you
many
for that.
years later.
We only had footage.
I almost thought of digging out an old picture. I think there's one of us in a mud puddle together.
But there is.
You're still in it.
Well put, well put. Well, welcome all of you to the mud puddle. So I'm Hannah Raven. I'm from Richmond Family Medicine, and I want to tell you a little bit about starting a new primary care practice, which I did with colleagues. We opened our doors 7 months ago in Richmond. And I'm going to first just show you a little bit about our clinic. So this is the view from the street in Richmond Village. This is the view of the same building from the parking lot. We have 4 doctors.
Is that a historical site of
It-
some sort?
Yeah, I'm going to tell you more about
Okay,
that.
good.
in a
Don't want to
little
miss
bit.
that.
So there are, we are 4 doctors, 4 family doctors. 3 of us are partners in the business, and we hired a 4th doctor as an employed physician who we hope will join our practice. We have 3 on-site consultants. We have a psychiatric nurse practitioner, a nutritionist, and a consulting PharmD, pharmacist, doctor of pharmacy, who works with us 3 days a week consulting and who is a professor at the Albany College of Pharmacy.
How often is the psych consultant?
Psych NP is with us 2 days a week. That may increase. And the nutritionist 1 day a week. And she's also starting to do some evening classes. So
I saw that on the sign up front. I drove by.
you did? Okay. So this is our team. This is how many people it takes to run our place, seeing patients and doing the administrative work.
All the people in the back just do billing?
We'll get there. We will get there. Exactly. So, in fact, let me go back just a moment just to tell you that we have, we do have 2 billing specialists, and I'll tell you that story. We have 2.5 receptionists. We have an office manager who I'll point out here, Mary Lahiff in the back. We have 1 full-time lab technician who runs our lab. We have an RN, an LPN, and 2 medical assistants who work about 3.5 full-time equivalents for nursing resources. So our patients are an expanding population. We see people of all ages in family medicine, from prenatal care to the very, very elderly, for whom we do end-of-life care, sometimes even in their homes. And it's all kinds of medical care that we provide. So this is our mission statement. We provide comprehensive medical care for people of all ages with an emphasis on evidence-based preventive medicine and acute and chronic disease management. We are dedicated to promoting the health of individuals, families, and our community. So our initiatives, really at the heart of our commitment is providing excellent patient care. That's what we do all day long. That's what we strive towards. We are working with the blueprint on becoming a patient-centered medical home. We are working to establish a teaching center within the practice, and in fact have had already a psychiatric nurse practitioner intern working in our practice. We'll have students from the Albany College of Pharmacy joining us at the end of the month. And towards the end of the summer, we'll start having students from the UVM College of Medicine who will rotate with us for a month or 2 at a time. And that will be on an ongoing basis. We also are working towards becoming a center for health in the community, not just for our patients, but really opening our doors to the community. We have a nutrition class, as Anya mentioned, a diabetes education class coming up. We are working towards having meditation practice in our waiting room when we're not there seeing patients. There's really the opportunity to open our doors and have the community come in to learn about health and to practice good health. So I wanted to go back a little bit to why we decided to start. And I was working in a large primary care office, another private independent practice, but it was a big practice. There were 14 providers, 10 partners, and it was a big place and hard to get things sort of moved in a direction. It felt like a very big ship that was hard to maneuver. I started talking with 2 of my colleagues about starting a smaller primary care practice. We felt that with a smaller group, we would have more agility in making decisions. We thought that we would be able to collaborate in terms of medical care. We could share information, share our knowledge, work together to take better care of patients, and also that we would find it more fulfilling professionally. So we also lived right near Richmond. All of us live in towns that are contiguous with Richmond, and we thought of Richmond as a really vibrant community with strong growth. They are working towards developing a very vibrant town center, and there's a really strong feeling in the community to keep things kind of local. There's a hardware store and a grocery store. People like doing business in town, and the dentist seemed very busy in town. So we thought that this was a town where we would like to work and where we might do well. We also recognize that around Richmond, there are towns that don't have doctors. So Jericho, Underhill, Starksboro, Huntington, Bolton, no doctors. So we started by looking sort of on the realty side of things. And we formed a little realty company, the Three Doctors. And we purchased an 1840s brick village house. This is the historic site that Alan is talking about. It's really a beautiful old building in the center of the village. And we designed an expansion to house the clinic, new space. We did this on our own. We downloaded ArchiCAD on our computer, and we designed the building. We knew what kind of function we wanted. And one of my partners, who's actually my husband, is a former builder. And so we took on the general contracting ourselves, and we did a lot of the labor ourselves too. So in true Vermont style, that's Dr. Terrio up on the left, Dr. Goodyear and myself top right, Dr. Goodyear bottom right, and myself and my daughter, Staining Clavard. So we really did a lot of the physical work for months to get the building off the ground. To finance the building, we had to buy the building, the land, and finance the construction. We took out second mortgages on our homes. We borrowed money from the New England Federal Credit Union and from the Vermont Economic Development Authority to buy the land and to start the construction. And then, beyond the cost of the realty, we had to outfit this building and get everything ready to open up and start to practice. So the costs were significant. Medical and office supplies. We had to buy an electronic health record and practice management systems. That's about $100,000 in down payment, with an additional, $2,000 to $3,000 or even more in monthly maintenance fees. We had to buy furnishings, exam tables, an EKG machine, otoscopes, and we outfitted a lab as well so that we could do lab tests on site. And then we had to start paying staff before we even started seeing patients. So this was where we probably could have used help from our friend Mr. Gobet over here, because we fell short. It was really hard to get money. We had sort of used our savings, used our equity in the realty company, and at this point did not have any accounts receivable to count as collateral. So we were short getting started. The first several months were definitely challenging from an income perspective. Our revenues were fairly good for a startup. 3 of us had brought a fairly large number of patients from our prior practice, but we were starting with a need to grow. We had one doctor who didn't have any patients to bring with her, and we were paying her salary from the beginning. Although revenues were good, the costs were high, and we definitely saw loss in the first several months. From the beginning, we've been able to pay our staff and pay our bills, but the partners aren't paid until everything else gets paid, and we're just now starting to see that turn around. So I just wanted to put up a list of what it takes to operate a medical practice from our experience in the last 7 months. Payroll and employee benefits is right at the top. That rolls around every 2 weeks, and it's a large chunk of money. Software maintenance, loan repayments, utilities, office supplies, medical supplies. The list goes on. You can kind of see there's a lot. And we're seeing growth. This graph shows numbers of appointments per month. And you can see it's been a little bit jagged, but definitely on the rise. And then I wanted to talk a little bit about, sort of going back to some of the administrative burdens. Before we even opened and started seeing patients, we had to do credentialing with the insurers. as you guys may already know, is really kind of it's kind of an extraordinarily convoluted and difficult process. So I wanted to talk a little bit about that. So beyond the uniform CAQH registry, we had to go through a lengthy and difficult form filling out or online process for each insurer. We had hired a credentialing expert to help us to navigate this process, but even she was often baffled by the process. Ultimately, we credentialed with 5 major private insurers and enrolled also with Vermont Medicaid and with Medicare.
It's like when my relatives come to me and ask, what should I do about Medicare? And I say, I have no idea.
Yeah,
These
it's
processes
really,
can be.
It's crazy. It's really, it's very, very complex. So, our mission to provide medical care to all patients regardless of their circumstances has compelled us to, to credential with all insurers regardless of their reimbursement rates. And we offer a discounted fee for services for our uninsured patients. And I know that that's different from some of the other nearby practices where we work. So, and then there's contracting, and what we found was that there was really no possibility to negotiate rates with the insurance companies. We could choose to be in their network and accept their set rates, or we could choose not to participate, which would mean that our patients who had those insurers would be, out more money. Often it was difficult to know what the rates would be. So, for example, we asked Cigna for a schedule of their rates, and they replied that we would need to send them a list of our 25 most common codes. So we did that, and they then sent us, after some time, they sent us a list of 2009 fees for 25 other codes, some of which included codes that didn't pertain to our practice at all. They were surgical codes, and we don't do that particular surgery in our office. And in trying to contact a representative, we were shuffled from one office to another. I mean, it was so baffling that it felt, sort of intentional on their part. Perhaps it wasn't. Perhaps it was just a matter of high-level disorganization. But it was hard to just even find somebody to talk with. And ultimately, we found somebody who said that the 2009 rates were not negotiable unless we agreed to have an on-site representative from Cigna in our practice on a daily basis who would help us to make medical decisions that would keep costs down. So needless to say, we did not agree to that.
You
So
should have done that, filmed it,
Yeah.
sold the film, and none of us would have to work again.
That's a good point. Maybe I'll call them back if I can find them.
Sure, come down and enlighten us. I'd love to see it.
So, so at this point, we're paid 2009 rates from Cigna, in 2012. And there's no possibility at this point of really negotiating that. We elected to do our billing in-house rather than outsourcing. I think that, there's the possibility of outsourcing. It costs somewhere between 5 and 8% of your revenues to do that. We thought we could do it more inexpensively with a powerful electronic practice management system, which we had purchased. And we thought that, we would be in good position to manage this with one biller. It became very clear when we opened that we really were short-staffed, and we hired a second biller. So now we have 2 full-time people who manage our billing, overseen by our office manager. Billing in primary care is really complex. There are some benefits. Everything is electronic, so you send in your claims electronically, you get back information electronically, either payments or the rejections, which you can then work often electronically. And so there is some efficiency that's built into that system. But there's still extraordinary variability in carrier coding requirements. I think that you pretty much have to have a coding expert on staff in order to do this, even though the software purports to being able to help with that. my office manager recently showed me a form, a stack of papers that contains 200 different codes which relate to the different reasons that insurance companies use to deny a claim. So somebody in the office has to know what those codes mean and how to work them. I think primary care also represents something that's quite different in terms of billing, because we see so many different kinds of patients for so many different diagnoses. We have a lot of different diagnosis codes and procedure codes that we're dealing with, and I've used the analogy of a mom and pop grocery store where you're buying a pack of gum and a stick of butter and a loaf of bread and hopefully some kale and some carrots as well, and you compare that to buying a car, which is a large purchase, which is more akin to what I think the specialists do in terms of their coding and charging. So since we opened, we've billed 232 distinct procedure codes. We average 3 procedure codes per office visit and 2 different diagnoses per office visit. So now I want to turn a little bit to the electronic health record, I'm going to say it, fiasco. It's, months before we opened, we researched various electronic health record systems, and we felt really daunted in this effort. There was a huge number of systems available, and each system is extraordinarily complex. And the costs of purchasing and maintaining a system are kind of overwhelming. So we knew that because 3 of us had existing panels of patients, many of whom would be following us, that we needed a system that would electronically transfer information from our old practice electronic health record, which we'd been using for a number of years, to to a new record system that we would purchase. So that was a key point for us, and we sought advice from Vital, but unfortunately found that their representatives were not effectively able to really elucidate the differences in the systems. Nor were they at all able to recommend any system. It seemed that they were really prevented from being able to say, I've gotten to know you, we understand what your practice style is like, this is the system that would work, or even these are the 3 systems that would work well in your practice. So ultimately, one EHR company assured us that the medical records from our old practice could be electronically transferred. And we bought that system, only to find as we opened that that was not possible, that the technology did not exist, that they were completely unable to do that. So we opened. We've been getting, sort of bits and pieces of medical records from our old practice. And we're often having to print out pieces of records in order to bring it into a patient visit to have the necessary information to make good, safe medical decisions. So this EHR and practice management product also, as it turned out, fell short in many other respects in terms of product support and training. It is a CCHIT certified product, but it lacks the ability to generate the reports that are needed for meaningful use. So we're ditching it. And that is just completely overwhelming from a financial perspective and from a new business perspective. I mean, taking on the training and implementation of one EHR over the course of many, many years has been overwhelming for many organizations, and we are undertaking to get out of our contract with this particular EHR, and we're buying another one. So that's the reality, and it's, as we transition to our new EHR, we're going to have to pay a company $16,000 just in order to get a transfer of basic information from our current system to the new system. And that's not even talking about the records from our prior practice. So I also just want to say that the notes that we create in electronic health records do not serve good medical purposes a lot of the time. I mean, I think none of us would go back, but the notes that are created are often difficult to read and sometimes don't convey medical information in an efficient and succinct way. And I think that that's a problem that ultimately will need to be addressed. So that's my big complaint about electronic health records. They're expensive. It takes a lot of effort to get through writing a note in the EHR, a lot of clicks without substantial positive impact on patient outcomes. It also allows doctors not to send tasks out to staff to do, so we do our own ordering of tests. The test results come back electronically, so we manage those tests, send out letters to patients. We do referrals electronically, we do prescribing electronically. And some of that, and we even do charge entry electronically. So in fact, I consider us part of our billing office because we're putting in the codes, we're putting in the diagnosis codes, finding what the charge is. So that actually puts a lot of clerical tasks on doctors who might need to be thinking about other things, other medical decisions rather than doing these kinds of clerical tasks. So, and we've talked about the limited communication between EHRs. And we just spend our day face-to-face with computers, trying to look over the top of the laptop as we are interviewing a patient. So, in our fee-for-service model, there are a lot of services that primary care doctors provide that are not compensated. We spend a lot of time doing forms, coordinating visiting nurse visits, referrals to specialists, coordinating with schools, guidance counselors, special ed resources. And all of that is done kind of behind the scenes, not in face-to-face visits with patients. Many of the services we provide include, things that might happen in our office, like family meetings, but sometimes those happen without the patient, and those you can't bill for. Additionally, we do a lot of telephone medicine. We have a full-time triage nurse during business hours, and she is often helping to determine whether a patient needs to be seen in the emergency room, whether they can be seen in our clinic today, whether they can be seen tomorrow or next week. And she's often dispensing advice that keeps the patients out of any medical facility at all. She might prescribe a medicine by consulting with one of the doctors, or give other kinds of advice. We're on call 24/7. So tonight, if I take the pager home, I could get a call from a parent of a child with an earache. And, if that parent doesn't reach me, that parent might feel compelled to go to the emergency room because a child in pain, is a very compelling reason to get help. However, if the parent calls me, I may be able to dispense advice that would keep the kid comfortable until we can see him or her in the morning, and that keeps patients out of the ER. We do get small capitation payments from some payers, Medicaid and Blue Cross. We get another kind of payment from Medicare that I'm not totally familiar with, but these are small, not very substantial acknowledgments of these additional services that we provide. So what would fix it for us? There's a lot. I feel like I've given you a long litany of complaints. Certainly standardizing the electronic health records, and that's a problem. I feel like we've opened Pandora's box by allowing the EHR companies to flourish and proliferate to the point where it's become big business and they don't really serve patients. So I think we're at a point where we're going to have to try to develop the technology to allow these systems to communicate. And so supporting the development of that technology and making it affordable and available, I think, is where we are. In terms of billing, I think consistency in billing rules so that we don't have to have, two people in a billing office in a small practice, so that we don't have to have experts who work the denials, or we lose that money. We need a unified and standardized credentialing process. We need transparency in fee schedules, ability to negotiate for fair compensation for the work that we're doing to take care of patients. And ultimately a payment model beyond fee-for-service that recognizes the comprehensive care that we provide in primary care. So I just want to say that I actually love my job.
Sure you do.
I do, you know, I do. You know, I work in a small town in a close-knit community, and, you know, that is extraordinarily rewarding. Also, the collaboration among the doctors and our consultants within our practice just makes it tremendously rewarding professionally. I feel really close to my patients. I feel like I can practice great medicine with my colleagues there. And I really can't imagine practicing anywhere else, and certainly can't imagine doing any other job. I do think that to keep our doors open, I mean literally to be able to keep going, providing care at Richmond Family Medicine, and you know, to sustain our current medical staff and ultimately to attract new doctors. I'm 12 years into practice. You know, I will retire at some point. You know, I can imagine working the rest of my career at Richmond, almost no matter what. But I also think that, you know, we need to think ahead and think about how to attract new doctors to primary care and to small practices like the one in which I work, because I think that, you know, this is a model for really good care, and so I think it's worth supporting. Thank you.
Aside from all the headaches, do you feel like you're at a point now where the model feels sustainable, even if you're hanging on by your fingernails?
I do. I mean, I think we're getting there, and I think that, you know, there's really a good possibility for, you know, for things getting much better.
Mm-hmm.
You know, I think that we're going to have to work things out in terms of, you know, billing and EHRs. I mean, those continue to be, you know, more than just headaches. I mean, they're really, you know, they really hinder practice.
You guys have questions for him?
Well, no, I'll just say that this process began for me, gosh, at least 2 years, 2 years ago when Dan was, one of Hannah's partners was doing some per diem work in my office in Colchester and would tell me all of these steps that you all were going through, and I thought to myself, if this isn't a model that we are both morally and ethically bound to support, really, what more important thing is there? I really appreciate you being here, and it takes me back to that statement that I use in the morning: how will this help the patient? And we know you're helping the patients in Richmond, and we thank you.
Yes, Karen.
When we've heard from the Blueprint side of things, and they talk about the encouragement and the ways in which they're trying to assist Blueprint practices, particularly around the adoption of interoperable health IT. So I'm wondering, you said that, you know, as a patient-centered medical home, that's what you are more or less heading for. Do you see yourself as being part of the Blueprint in a very close way? And if so, what's your timetable and your thinking? And how do you think they could help you with these two thorny issues around health IT and the other major problem around contracting?
Yeah. So we actually actively are working with Blueprint right now to become a patient-centered medical home and, you know, Blueprint certified and all of that. So we are working with them. And, you know, they've been involved in our process of deciding to ditch our old EHR and start with a new one because, you know, we couldn't become a patient-centered medical home with our old one. We can't generate the reports that are needed. So, you know, we sort of found ourselves up against a wall even with Blueprint. So, you know, it was partly through the advice of the Blueprint person that we're working with that we've chosen another EHR and are going that route. You know, I think it remains to be seen sort of how much Blueprint opens the door to better reimbursement, to you know, more access to good patient services, you know, through the community health teams. You know, we're kind of building our own little community health team already. which feels necessary and sort of urgent, partly because it allows the doctors, if I don't have to do all the nutrition counseling but can actually send a patient on, then I can manage the next patient who comes in with heart failure, and, if I can send somebody for smoking cessation counseling, that I don't get reimbursed for, but that somebody in my office needs to do, that unburdens me to take care of the next thing. And certainly we all do a lot of this kind of counseling with our own patients, because sometimes patients hear it best from their doctor. But to have other resources really does help us to more efficiently, I think, take care of patients' needs.
How burdensome is the process of becoming a Blueprint practice?
It's pretty big. Yeah. And it's, right now we're finding that we're overwhelmed with projects, practicing. I mean, I see patients 4 full days a week, and take call in addition to that. And, the burden of paperwork that I was telling you about literally involves, or paperwork or computer work really, is about 2 to 3 additional hours for every full patient day. So I spend a good chunk of time doing that. So to in addition, take on the projects that are required by Blueprint. On the other hand, I feel like they're, in fact, the kinds of things that we want to do. They're really health improvement projects that are, I think, key to being the kind of practice that we want to be. We want to involve patients in, how to better serve them. So we have, a plan to invite a panel of patients to come talk to us about, how is it to actually hear from your doctor about being obese? How can we say that in the most sensitive way that you can hear that is meaningful? So we're going to have a patient panel, to discuss that. So I really feel like it's continuing to support us to work in the direction that we want to work in, but it is a lot.
Other questions? I'm sorry, I thought
After you got open and you weren't really making money yet, how did it feel the first time someone came in and asked for a donation? Do you remember that at all?
A donation, you mean?
Like, the Flynn. Like, I remember I bought the shanty and I'm like getting through the winter and I got like 2 nickels to rub together, and they came in and like, now that you own a restaurant,
Yeah.
we thought that you would want to be, and I'm like, are you crazy?
Yeah.
Like, you can take my pickup truck and put that toward my thing. It's very, very hard. No one if you haven't put your name on the line, I mean, I totally know where you're coming from. The only thing I could dive into is every decision that you make, is there any other way to save, cut back, do whatever? And that's just normal business stuff,
Yeah. We'll take any suggestions.
How much debt you got? Who's your bank? Call me. We'll get your interest rate down. That's the stuff that kills you. Yeah. But no, the stuff that kills you isn't always the stuff you think it is. An old building, just the repairs and maintenance is probably, you think you just built it so you don't have to do anything. Yeah.
So on the administrative burden front, you can expect that we'll be back in touch with you, because this is an area that we're very interested in, and would like to pursue some fixes
Great.
in fairly short order. So
Great, thank you.
give us your list, your top 10.
Oh, yeah. Maybe we'll hear back from you better than from seeing the top 10 list.
Yes. Yes, we promise you will. All right, any other questions for
Thank you.
Hannah? Thank you so much. This is
Thank you.
incredibly valuable to hear what's going on at the ground level, and you do great work. So,
Thank you.
thanks.
Thank
so
you
much.
very much. Thanks for working so hard.
Yeah. All right, so I think we now have Georgia.
Good.
Nothing about primary care coming out of her.
segment, I'm sorry, it's data analysis, which is boring. So in front of you, there are 2 separate requests to execute contracts. I'd like to do the first one, which is the longer one, to execute a sole source contract with policy integrity. So as we've discussed many times in public, and a lot of other times, the board needs reliable data and analytics to do its work. And we've
I
been...
don't know, we could just make stuff up.
We could. But we're attempting to use an evidence base for our decision-making. And to that end, Ani had asked me to figure out how we can do that. So I've come up with a short-term solution and a long-term solution. And the reason for doing this is our need is pretty acute. We have to get moving on this like last week. So the overall structure of the plan is that we will hire a contractor, Policy Integrity, to work with me to make sure that we have reliable data sources and that we also coordinate our analyses with other state agencies of these data sources, and that we build internal capacity. Which then leads to the long-term solution, which is we are in process of filling a data research coordinator position. And that the hope is that our contractor can train this new person to take over the majority of the analytic and coordination work in the next 4 to 6 months. You'll note that the contract is a sole source contract, and that's for a couple of different reasons. One is that we'll be relying on 2 major data sources, VCures and the Unified Hospital Discharge Data Set. And Policy Integrity has significant background working with these data sets and developing them, and knows how they go together. Additionally, since we'll be working with other agencies, Policy Integrity has worked with state government and other government agencies. Steve Capel of Policy Integrity actually teaches data analysis and policy analysis, so it's helpful that he'll be doing some training. And additionally, they can start work immediately, which is a key piece for us. The contract is for 12 months with a maximum of $78,000. That's for about 10 hours a week. I don't expect we'll need the full 12 months. The hope is that we can hire someone and get them up and running, but I'd like to hedge on that one, just to make sure we have what we need and we don't have any gaps. There's a list of the deliverables, which include working with the existing systems, complete Medicare and Medicaid integration, and then doing some enhancements, because there are pieces that we need added on to both VCures and the Unified Hospital Discharge Data Set for our work specifically that weren't contemplated prior to our existence. And then there's analysis components, which includes training, coordination, and then quality control and review and analytics.
So you need, well, first of all, I'll just say from my own personal perspective, I welcome this because I think the coordination with other state agencies and sort of riding herd on getting our data resources in shape up to this point has been falling mostly to Georgia and myself, and we neither have the time nor the expertise to do this well. And so this would be a way of doing it better and making sure that it's done consistently, because what we have found is if somebody isn't riding herd on this and understanding geek speak day to day, it starts to very quickly get bogged down. So,
Can I ask, that is it the expectation also of Policy Integrity that they will be working very closely with our long-term solution, which is our data research coordinator, and so
they'll be
there's not-
training that person.
They should be training that
Is
person.
So that, because that, I don't know, is that a deliverable or just an expectation?
That is a deliverable that we can put more clearly in the actual contract terms.
Yeah, that's
when we build that.
Yeah. There's just
Training,
one line that
okay.
says
But we can-
training, but
But
that's
we
what
can
that
make that
means, yeah.
clearer, thank you.
Al had his calculator out, would you?
Well, my only concern is, I just want to clarify this, so it would be for 10 hours a week,
Right.
that's $78,000 for a year.
Yes, I think, unless I did my math wrong.
That's what she said.
Just,
That's what she said, I think.
is that a good value? You know what I mean, is that a not to exceed? Could it
That's a
come in
not-
less?
Yes, that's a not to exceed.
Yeah.
Maximum, it says.
I mean, I think relative to, I don't know what the full cost of the data analyst position fully loaded is.
Fully loaded, it would probably, well, we haven't hired them, so we haven't actually done that, but in the range of 70 to 110 fully loaded a year, bearing in mind that my understanding about the market for these services, which is why it's been hard for us to find someone, is that there are very few people who have this skill, and when they're trained in certain venues that perhaps might offer them a lower salary, they are then quickly snapped up by other private entities to pay them a much higher salary. So the kind of standard, I understand, is between 60 and 80,000 a year, but it's hard to keep people on staff at that range that they really.
And this is a problem throughout
This is
state
a
government.
problem
But
throughout state
basically,
government.
so we can get a full-time person year-round on staff with a lower level of expertise for roughly the same amount. So this is a more expensive person for a quarter of the time.
To train our
Yeah, so,
person so that they can do the bulk of the work that we need done.
but the hope would be we could phase into the in-house person as quickly as possible.
Yes.
Okay.
All right, do I have a motion to approve this?
Make a motion to approve the request for approval to execute a sole source contract with Policy Integrity for up to $78,000 in the next year.
Do I have a second?
No second.
All in favor?
Aye.
Aye.
Okay, thanks. Next one.
The next one, also data analysis. It's day-to-day.
Kill us.
Last week, the board approved to execute a contract with VOZ NSO for processing and warehousing data related to the Unified Hospital Discharge Data Set. A gap in my knowledge at that time was that apparently VOZ NSO also provides some analytic report in relation to this contract, and that actually is for a separate contracted amount of money. So this will be added to the contract that the board approved last week. But really is to provide specific analytic support related to the Unified Hospital Discharge Data Set. I'm going to stop saying that or give it a better acronym. And as well as they are capable of merging information with VCures on their side. And it would be for $20,000, not to exceed $20,000 a year for 2 years, since the contract we're piggybacking on is a 2-year contract. Just so that the board knows, there is other analysis that's done through memorandum of agreement with the Department of Health on this data set. So there's a significant amount of state resources that go into analyzing this data set and working with it. But we felt this to have a little bit of flexibility within this contract for this work. Every project will be approved separately, so there's no standard analytics. It just gives us the capacity at VOZ NSO to do this work.
Move
They've
to,
already been doing some work around the bundle payment
They have.
pilots,
Yep.
right?
They have, yes.
move to approve the execution of the additional terms to the VOZ NSO sole source contract with an amount not to exceed $40,000 for 2 years, approximately $20,000 per year.
You have a second? Second. All in favor?
Aye.
Thanks. All right, I think we are ready for public comment, if there is any. Going once, going twice, going. Thank you all.